Welcome to our second video on postoperative fever. In this one, we'll be focused on late and delayed causes. So here's our overview figure, and let's start our discussion with late causes of postoperative fever. Usually when we're referring to late postoperative fever, you're thinking between days 4 to 30. And during that time, patients are at risk of developing DVTs or PEs. And sometimes medications can cause a late postoperative fever as well. For example, antimicrobials such as vancomycin and beta-lactams, anticonvulsants such as phenytoin, or anticoagulants such as heparin are the most common culprits. Now, C. diff and a surgical site infection can also cause a late postoperative fever, but we discussed that previously when we're talking about early postoperative fever within those first few days. So the point is just to know that a surgical site can become infected and cause a fever during the first 1 to 3 days, or it can happen after that. But for the purpose of this lecture, especially since we already discussed surgical site infections and just infectious etiologies, we're going to focus on non-infectious etiologies. And that's pretty much how you should start thinking about postoperative fever. Like early, you're thinking about infection, and then over time, you're worried about other things like DVT, PE, and drugs. So now let's talk about the clinical features. So postoperative patients with a pulmonary embolism present with a sudden shortness of breath due to hypoxemia, and they can have pleuritic chest pain, and that's because of the inflammation of the pleura, and they also have tachycardia, and that's a compensatory response because of the decreased blood flow. And sometimes, not always, they can have hemoptysis, which is due to ischemia and necrosis of the pulmonary parenchyma. Postoperative patients with a DVT present with sudden throbbing pain in the calf, and we believe that pain is most likely related to ischemia and the resulting inflammation. And on physical exam, you can see local swelling and warm redness, and that's due to the endothelial damage and inflammation as well. So here we can see a large PE at the bifurcation of the pulmonary artery. And this is performed with CT angiography. Sometimes you'll just hear this as a CTA. And here you can see a DVT of the right leg. Notice that swelling and redness, and oftentimes that pain is more posterior or even in the thigh, but it can appear like this. Let's continue with drug fevers. So patients typically have nonspecific symptoms if it's caused by a drug, and you're thinking like fever, chills, fatigue, super nonspecific. And because it's so nonspecific, you need to remember that a drug fever is really a diagnosis of exclusion. So you're going to rule out those other possible causes of late postoperative fever before you ever make this diagnosis. And postoperative patients with C. diff present with abdominal cramps and tenderness and watery diarrhea. And the most important clue in history for a C. diff infection is a history of recent antibiotic use. Recall that antibiotics can disrupt the normal intestinal flora, and that allows C. diff to proliferate. Okay, so how do you diagnose these? Well, a DVT, when you suspect it, you're going to want to get a Doppler ultrasound, and that can evaluate for abnormal blood flow and the presence of thrombi. And CT angiography, which I showed you before, is indicated for patients with a high likelihood of a PE. And if you're not as suspicious of a PE, then you can get a D-dimer because that can help you rule it out. But again, you're only going to do that if there's a low likelihood of a PE, because if it's high enough, you just want to get a CTA. Now for the diagnosis of C. diff, a PCR is recommended because that can help you detect toxin B in the patient's stool. So you're doing a stool sample and do a PCR of that. Also, an X-ray or a CT scan can be ordered to see if there's wall thickening or perforation. So basically complications from the C. diff infection. We won't go too deep in the workup of those conditions because they're covered comprehensively in other lectures that focus just on those pathologies. But here we're just trying to focus on the causes of postoperative fever and how you catch and treat it. And with that in mind, I just want you to see a C. diff gram stain, and you can see them here, and they're gram positive. So that's a gram stain, but again, the recommendation if you're really trying to dial this in and determine for sure if it's a C. diff infection is get a PCR. Lastly, let's talk about the treatment of a DVT and a PE. So anticoagulation should be started, and you do that with heparin, and then you bridge that to warfarin. That's because warfarin takes some time to actually get started. Now in severe cases, for example, if someone has hemodynamic instability as a result of the PE, and that's possible because PEs can be large, severe, they can be saddle emboli that can cover both pulmonary arteries, really just crump the patient. In those situations, you're going to want to do thrombolysis or thrombectomy. Inferior vena cava filters can be used to prevent pulmonary embolism if the patient has a contraindication to heparin or warfarin. There's more nuances that you can learn about in our other lecture focused on DVTs and PEs, but But again, we want you to just recognize this, have this in the back of your mind, not only in preparation for your surgery shelf, but just so you can have this fresh in your mind for a postoperative fever patient. And how do you treat C. diff? Well, the best initial step to manage C. diff is, of course, to discontinue the offending medication, because typically you're assuming that an antibiotic caused it. Again, because it disrupted the normal intestinal flora. So stop that medication. And then ironically, you're going to give another antibiotic that's directed at C. diff. And most commonly, that would be vancomycin and infidaxomicin. In patients with severe or refractory disease, they may require something more advanced like surgery, but we won't go any further into that. Just know that you want to treat the C. diff infection with an antibiotic and discontinuing the offending medication. So here's our overview slide. Now that we've discussed late postoperative fever, let's wrap up with delayed postoperative fever. So delayed postoperative fever occurs 30 days from the surgical procedure, and it's typically unrelated to the surgery, which makes sense. It's been over a month. However, infections of implanted devices and a fistula could be potential causes that are technically related to the surgery. And that's about all you need to know about delayed postoperative fever. It's super distant from the actual surgery or the operation, but you're thinking that maybe there's something like if there's a total hip replacement, maybe that there was some infection on the actual prosthesis. In that case, you're going to consult ortho, but in general, you just think intuitively, because a delayed postoperative fever could be anything, even things that aren't related to surgery. So in some ways, just think of this as a blank slate. Patient hasn't had surgery. What do you think it is? And then you think, okay, they've had surgery over a month ago. Is that related? And then just think intuitively about that. But that's all you need to think about. So now that we've covered the late and delayed postoperative fever, in addition to the immediate and early causes of postoperative fever in the previous lecture, let's wrap up with a board-style question. A 55-year-old woman is evaluated for watery diarrhea that started 3 days ago. She underwent emergency cholecystectomy for gangrenous cholecystitis 2 weeks ago. She has been on broad-spectrum antibiotics since the surgery. Her past medical history is significant for poorly treated type 2 diabetes mellitus. Her vital signs include a temperature of 39 degrees Celsius, a blood pressure of 130/80, a heart rate of 92, and a respiratory rate of 16. The physical exam shows a non-tender, non-distended abdomen without guarding and rigidity. Stool PCR for toxin B is positive. Which of the following is the best treatment option for this patient? A. Erythromycin, B. Vancomycin, C. Metronidazole, or D. Exploratory laparotomy. So this patient has watery diarrhea and a fever 2 weeks after cholecystectomy. So the time frame of her fever is consistent with a late postoperative fever. And again, that would be 4 days to 30 days. And since the time of her surgery, she's been on broad-spectrum antibiotics. And we know that it's C. diff because the stool PCR is positive for toxin B. So we know it's C. diff. So the question really is about what antibiotic do you give them? Well, the correct answer is B, vancomycin. So here we have the slide reminding us of the treatment of C. diff. Remember, discontinue the offending medication. So whatever broad-spectrum antibiotics she was on, you're going to discontinue that. But that wasn't an option, so we assume that they're going to do that. And then vancomycin or fidaxomicin. Those are the options. So again, B is correct. Now let's discuss why the other options are incorrect. Option A, erythromycin, is incorrect because it's not used in the management of C. diff infection or pseudomembranous colitis. Now option C, metronidazole, is incorrect because this is typically used in patients with a fulminant C. diff colitis, and that's characterized by hypotension, tachycardia, and toxic megacolon. However, even in fulminant colitis, vancomycin and fidaxomicin are still preferred over metronidazole, and that's actually a change within the last few years. Now finally, option D, exploratory laparotomy, is indicated in patients with colonic perforation and peritonitis, really just complications as a result of the C. diff infection. But we're not expecting a perforation or any of those complications because she has a normal abdominal exam and her vitals are stable. So we don't think we need to go to surgery. So again, the correct answer is B, vancomycin. And that concludes our lecture.